Good morning. Assalamu alaikum. I think we are behind schedule, so we'll try to move on quickly, although I know we're giving you heavy breakfast in the morning, lots of good talks. So welcome to the GIS, and you are now GISer, or you're a guesser, one of the two. So anyhow, so this session is a continuation of the same challenging cases and scenarios, and of course, left main is one of the things that we always think about, and we try to see what's the best strategy and how to treat and more challenging cases. I remember when I started my interventional fellowship training, that was a few years back. Left main was not in the menu as a routine cases, but eventually start to become more routine cases. So today I'm pleased to have a panelist and a group of co-chairmen with me, and I'm going to start with Dr. Abdullah Nami, who's our senior interventional cardiologist from the United Arab Emirates. Abdullah, I had a great time with him at the fellows course in San Jose a few years back, 25 years ago. Anyhow, and then Dr. Abdullah Al-Khshail as well, who's from Bryn Sultan Cardiac Center in Riyadh. Dr. Fuad Saeed is not here, but Dr. Hadi Abu Hantish, who's from Jordan, senior interventional cardiologist, a friend and a colleague. And of course, one of our well-known interventional cardiologists now in Riyadh, Dr. Salih Ashlash from King Fahd Medical City, our previous home, as I say. Anyhow, the first interesting case is it's going to be by Dr. Mohaned Egred from UK. He's going to talk about the management of left main with a trifurcation lesion. So Dr. Mohaned, welcome, please.
Good morning, everyone, and thanks for Professor Abdullah Shihab and the organizing committee for the nice invitation. In fact, it's Mohaned rather than Muhammad, just to make the correction. My task this morning is just to talk to you for the next 10, 15, or 12 minutes about left main trifurcation tips and tricks and about its management. These are my conflict of interest. So I'm going to space my talk into kind of 4 sections, talking a little bit about left main BCI, why is it important and what we do with it, and then talk a little bit about left main trifurcation, its presence and how we manage it, and there's some tips and tricks, and at the end maybe show you a case or two. Why is left main special, particularly with BCI? We all know that they come in different shapes and sizes. Because the myocardial jeopardy is quite huge, the left main probably provide more than 60 to 70% of the perfusion to the myocardium. So it's quite important how you handle it. There are important branches. The angulation makes a huge difference how you approach it. The size of the vessel can be different, can be large and small. And almost invariably, you require 2 stents, depending on the anatomy, obviously. And the presence of left main coronary artery disease or stenosis is a marker of clinical risk. And of course, aren't our patients lucky? Because there are multiple things you could do. There's surgery, there's BCI currently, and of course, medication remains also a cornerstone of treatment. And in the old days, obviously, BCI, it was just mentioned recently. Left main stem was a kind of a taboo for any BCI. It used to be the surgeon, and slowly, the interventionists were trying to get into this domain until we found out that the result with BCI, if you do it rightly and you kind of do it in the right way, under IVAS guidance perhaps, the outcome is similar. And this has been proven up to 15 years now. This has changed, obviously. It used to be the surgeon who's got them now. The interventionist probably doing most of the work. And despite all this, left main intervention is about 4 to 5%. This is data from 2016 from the British Interventional Society, and the latest one was 4.8. So despite all the advancement, it's still the percentage of BCI to left main remains a little bit on the low side. This is my experience. I started in 2008, some time ago, and late in 2008. And slowly, this is becoming really a very common theme of doing left main BCI regularly. I probably perform about up to a 90 a year, as you could see. This is all surgical turn down or complex cases. And out of these, about 11% are trifurcation. So trifurcation left main is usually the most common anatomical variation of left main. Most of the registries or the study have shown it to be between 10 to 15%. And it is important because there's at least 4 angulation between the 3 branches and the wide variability. And this is completely normal. We know that coronary arteries are almost like the fingerprints. You don't ever find a coronary artery anatomy similar in any 2 patients. And of course, you know, the trifurcation has to be considered with any branches that originate within 3 millimeters of the left main. It doesn't have to be coming directly from the left main. So if you see a high OM or a high diagonal that comes within 3 millimeters, that would continue to be considered as trifurcation. And this is kind of a demonstration or schematic presentation of the trifurcation. As you can see, there are 4 different angulation that you have to consider between the left main, the circumflex, the LAD, and between the other branches. And with this comes, people like to have a classification. But it was found that in non-white people, you could also have the left main divided into 4 branches, or sometimes rarely up to 5 branches. Why is this important? Because when you're trying to tackle this by percutaneous intervention, that's not an easy task, and that's not an easy lesion to deal with. And it also was found that the left main stem, when it is trifurcating, usually quite longer than it's bifurcating. There's a huge difference. This was one study showing the average between 9.7 and 6.4 if it is not trifurcating. There are 3 different classifications. The most common one remains the modified Medina, and that most people are familiar with. Does that make any difference? Particularly the last one, which has been recently published, the ABCD. I don't think that makes too much difference. The Medina remains the most commonly used one. And with that in mind, looking at the anatomy of the trifurcating left main with the 3 branches and the 4 angulation, you could have up to 15 possible morphologies. And this is just a little schematic representation of what could happen. You could have the disease in all of them, which if you go back to the IVUS studies that was performed in bifurcation, up to 62% you will have all the branches included. And this is exactly what was shown in one of the registries. And of course, you have to take into account, as I mentioned, if any branch is within 3 millimeters of the left main, and if the size of the side branch is more than 2.25 millimeters. And with that in mind, not all trifurcation are similar. There are different clinical risks, and geographic pattern also different, and the lesion morphology is different. And because of that, that will determine your treatment approach. Because you'll be concerned about side branch occlusion, you'll be concerned about the peri-procedural complication and infarction, stent thrombosis with too many metals and too bifurcating stents and so on. The presence of calcification, tortuosity, all plays a role in how you handle these and how you approach them. Because to my mind, left main BCI is not a normal BCI. You really have to be very meticulous how to handle that. So what is known about left main trifurcation BCI? There are few studies, about 8 of them, between 2008 up to 2016. The latest publication was from the Excel trial. That was a retrospective kind of subgroup analysis. I'll come to that in a minute. But as you could see, small numbers, not a huge number. The largest was the Medistra registry in 2016, with 92 patients in. The last one was, as I said, the Excel trial by Kandasari and et al. This was published last year, or a couple of years ago. 10% of the population of the Excel, which is consistent with what's been published, were having trifurcation. And the analysis showed no difference, whether you have a trifurcation or bifurcation. If you do the BCI properly, the outcome is similar. And there was no difference up to 5 years. This is the Medistra left main trifurcation. The only difference, if you could notice here, was the syntax score, which is intuitive because syntax all comes based on the how many bifurcation and the left main involvement and so on. So there was many higher syntax score and also the more left main with 3 vessel disease, as you could see in this view here. However, the stent strategies, there was only 18% were done with single stent, and the majority of them, 44%, with 3 stents. Now, of course, to my mind, again, as I mentioned, the more metal you have and the more complex the procedure, the more problem in the long term. The cardiac death, the MI stroke, they were all different in the trifurcating left main, and any BCI that involves many stents had a little bit worse outcome. Don't forget, this is a registry, so you always have to take the result with a pinch of salt, and you have to be careful how you interpret them. But this is an indication because this is consistent with the majority of the registries and the publications. You could see the maze here according to trifurcation type, whether it's through trifurcation or not. And again, if you have a trifurcating left main, the outcome was not as good, although with the free survival, the p-value was just about positive. I'll skip on this one. So when you're doing a left main trifurcation BCI, what are the considerations that you have to take into account? Obviously, in any left main, really, you have to be ready to deal with any, because it is a complex procedure. It's always better to go with 7 French. I don't think I perform left main with 6 French. But particularly with trifurcation, if you're using less than 7 French, you need to be prepared. You might have to use 2 guiding catheter to deal with that. Guide wire, you may choose to wire all the branches. In my own practice, if I decide from the beginning that I am not going to deal with the side branch, often I will not wire it. But a lot of people feel more comfortable having a wire down. Of course, wire wrap that people talk about is important to make sure that you control all that. It's paramount that the lesion is very well prepared, as in any BCI. But in particular, in the left main and bifurcation and trifurcation, the lesion need to be prepared very well, whether with cutting balloon, rotablation, whatever is needed. And this takes you to the intravascular imaging that will guide you to what you need to do and whether you need to use a debulking device or just a normal non-compliant balloon. On occasion, you might have to consider mechanical support because these patients come impaired left ventricle and all depends on the involvement of the right coronary artery. Of course, depending on the lesion type and the anatomy, then you decide whether you go to single stent, 2 stents, or triple stents. Triple stents, I have to say, in my own practice, probably in the last few years, I hardly ever used it. And that probably tells you what needs to be done. You always, once you put 1 stent, if you are going to go through it, it's always try to open the struts, not to cause any problem, because there has been cases where the stent got stuck and you brought the previous stent in. So always post-dilate and open the strut. And you could use any of the bifurcation technique, but of course, it is double usage because you have more than 1 bifurcation if you separate the trifurcating branches. Of course, sometimes you do have to come to innovative techniques how you do it. And be liberal with kissing. It is very important to make sure that the stents are well deployed, well opposed, and that comes with the kissing balloon after the original post-dilatation to each stent separately. There's the phrase being trissing, which means using 3 balloons. Again, rarely ever used in my hands anyway, but I know a lot of people use it. This is just kind of a representation. The first case was done with a single stent across from the left main to the LAD, and the struts open to the circumflex and the intermediate. The one on the bottom is 3 stents, again, left main to LAD, then to the intermediate, then to the circumflex. Multiple ways of doing it and multiple technique. This is a case I just done recently in June. Again, a gentleman with acute coronary syndrome, and as you could see, there's a severe stenosis in the ostial intermediate, and the left main was calcified and diseased. IVUS showed heavily diseased left main. The 3 vessels were wired, as you can see. Okay. And then the first thing I did was treating the intermediate vessel. This was pre-dilated, treated with drug-eluting balloon, something I quite often use, and I'm just wondering, can you just have 1 more minute, please? We
Yes,
use a lot
please.
of,
1 minute extra,
yes,
please.
1 minute extra, almost there. Right, so pre-dilatation, drug-eluting balloon, then we finished the case with in this case was a bifurcating at the end Kilot technique, and this was the final outcome after post-dilatation, kissing balloon, and this was the outcome. As you can see, the intermediate still patent to me3 flow, despite the ostium showing some narrowing. It's not important. The angiographic perfection is not what you're aiming for. You want as little metal as possible. So I'll just leave that in there. So all bifurcation technique can be used for trifurcation, but you could use them multiple times. And less complex technique usually give the best result. And this has been born recently with the EBC trial, if you'll be familiar with. The more complex lesion, syntax more than 30 through a trifurcation, have worse outcome in comparison to non-trifurcating left main. And also, meticulous planning is really paramount. Important to make sure you plan and you do it the right way, and you use all your BCI technique. And with this, I'll just say thank you, and happy to take any questions.
Thank you very much, Dr. Mohammed. I have a couple of questions for you.
You're
First of
insisting
all-
on calling me, it's Mohaned. Sorry.
Mohaned, okay, Mohammed. Sorry. The role of imaging to really check is it really a true trifurcation? Do you really recommend that you start with proper intracoronary imaging, understanding the angulation and the anatomy?
Well, I mean, imaging nowadays is probably becoming the most important, most significant part of planning your procedure, and particularly in left main stem. In order to get the best outcome, you really have to know what you are dealing with. It's easy for us to go in, just put a stent and come out without knowing whether you've done a very good job or not. And I think IVAS will guide you, first of all, how to plan your procedure, will confirm that what you have done is the right thing and you've achieved a very good result. So the long term will be excellent.
Hadi, please.
Thank you, Mohaned, as usual. A couple of things. I learned a lot from you, and I'm sure the audience, I don't know how many of you focused on that slide, which says any branch which is within 3 millimeters after the distal left main is considered a trifurcation. I like that because we sometimes struggle calling them high marginal, you know what I mean? And I like that because that makes a difference in how you approach the patient in the procedure. Let me ask you a question, Mohaned. I was looking at that you can use all bifurcation techniques for trifurcations, but I'm trying to think, though you don't use 3 stents, and I don't, a lot of us don't, can you collect 3 stents in the left main trifurcation? I mean, it's kind of...
That's a very good question. Yes, you can. I have seen people do crazy things. And this is the whole point, is about being practical and being pragmatic how you approach these lesions. You could do anything. And of course, when you're standing there, nobody's going to stop you from doing 2 kilos. And I've seen people do even double crush from the intermediate to the circumdent. This is not what we should be doing. And this is really an educational thing. The less metal and the less complicated approach, the much better outcome for the patient and for yourself. You might be pleased at the end looking at a very good, nice angiographic appearance, but it's the long term that you're looking forward. And I think the more metal definitely is not the right thing to do.
Thank you.
Good morning, Dr. Kamal Ayub from National Guard. I have one question for you. You mentioned 7 French sheet, and you mentioned 8 actually French sheet, and as well so my question, I mean, are you still doing femoral PCI for left main, and whether is this really, I mean, do you really need to do like a 7 French or 8 French sheet? Because I think this is kind of, we stopped doing it, I mean, in our practice. So I'm just want your insight.
Yeah, definitely not femoral. This is all radial. 99, well, the default start is always radial. And with the presence of the slender sheath right nowadays, which is 6 and 7, the outer diameter is 6 French, but you could still use 7 French in it. The 8 French is very rarely, I have to say, I use. But if you're thinking about left main, nowadays, obviously, we have the IVL So you don't have to have the big burr if you are going in, because the 2.25 or 2.5 burr, if you are going to use rotablation, does not go in 7 French. I always say and teach any of the junior, when you are doing angioplasty, you want to be fighting with one thing and one thing only, and that's the lesion. Take a small catheter, take an unsupportive catheter. You'll spend your time, more time trying to keep it in place, try to push stuff through it. When you're doing bifurcation or trifurcation, you're going to do kissing balloon. You might need the IVUS at the same time. We describe a way of kind of tackling the ostium to make sure by having IVUS and a balloon at the same time. So it's easier to have the space. All the procedure, they start as radial, 6, 7, and 7 French allows you to do whatever you want. In fact, actually, I could refer you to one of my publications about the ease of using 7 French in all complex cases. It's easily done. It's not femoral. Femoral only if you fail by the radial.
I think for the sake of time, I would like to thank you, Dr. Mohaned. Apologize for making a mistake on your name. Mohammed is a good name, though.